You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. DeBaun, welcome to the Nailed It Ortho Podcast. So happy to have you on.
Thank you, sir. Thanks for having me. It's so good to talk about a really important topic that can affect all of us in orthopedic surgery.
Yeah, and it's crazy. I was just telling you before that we started this, we've had over 200 episodes, but somehow have never touched base on this very important topic of open fractures, you know?
Yeah, for sure. So today's discussion is about open fractures, and obviously it's something that, every orthopedic surgeon needs to be comfortable managing with ED management and getting through call and what have you. So I appreciate you bringing it to the forefront of our attention. Let's get after it.
Yeah, of course, 100%. But so when we start off our podcast, we start off a couple of questions, just kind of getting to know you a little bit better. So, the age-old question, we have residents that listen to this. We might have some third-year residents that are trying to figure out what specialty they want to go into. What's the kind of the story that behind it or behind you that had you choose trauma?
That's a great question. Got into orthopedics like most of us because played sports growing up and in college and wanted to be the Lakers team doctor, right? Like wanted to sit on the sidelines and be on the court taking care of athletes, like folks that, kind of took care of me when I was hurt growing up and in college. So that was initial like interest in orthopedics. And then I realized, early kind of an intern year that the real team sport was trauma. I really enjoyed being part of like a multi level team where, you have students and junior residents, senior residents, attendings all working as a team to try to take care of the workload, starting with fracture conference in the morning and getting through the day and really vibing that way. I think that team culture for trauma was really, really enticing. And then I also had the privilege of having great mentors at Stanford residency, folks like Michael Gardner, Julius Bishop, Mike Bellino, and Dave Lowenberg that were all in trauma and all had different kind of style, but pursued excellence in their care and their management. And I like the creativity of trauma. I like the fact that, you could have principle-based thinking that kind of is your goalpost, and then use the principles that you learn and try to be creative to have like, nice looking constructs and x-rays for your patients. And I like the craftsmanship of trauma. So that was some of the things that interest me, early on as an intern and kind of never looked back.
Yeah, I do agree with you. Trauma is definitely a team sport, right? Because not only the team of orthopedics, but depending on the complexity of cases, you're also dealing with general surgery and maybe dealing with uro if the pelvis fractures, and so definitely agree. It's definitely a team sport, as well as one of the things I've noticed that their mentors have a big part, as to what you do, right? We've had a lot of people on, and that's a recurring theme. So super glad that you had your mentors, and hopefully you're going to be a mentor to some young physicians, upcoming
Absolutely.
orthopedics.
Yeah, part of the game is lifting as you climb, right? So paying
Yeah,
it forward and helping the next generation. So I'm happy to be here to talk about.
yeah. And so next question is,
Yep.
just general question. Do you have a favorite case? Something that you like to do?
I'm a trauma surgeon at heart, like fracture surgeon at heart. So my favorite cases are pelvis acetabulum for sure.
Oh
And
man.
it's it can be the start of life and hopefully not the end of life, but it's something that's always energetically entertaining and challenging, and it really is that pressure that I enjoy, with some of those more complex pelvic and acetabulum injuries. So yeah, that's definitely going to be my number one, but close second is going to be, basically deformity work or work related to nonunions, malunions, and trying to revise constructs that I get referred to if the first go didn't work from from whatever which reason. So that's kind of a challenging too, fun thing to do
Yeah,
too.
definitely. Yeah, I definitely feel like you gotta love pelvis or acetabulum. Like all the people that I know that love pelvis and acetabulum, definitely, they go into trauma. That's
Yeah, yeah, you kind of
that's their
know it
thing.
early. Yeah, either you love it or you don't.
Yeah, yeah. I mean, I enjoy trauma. Not,
There you go.
I'm not the pelvis acetabulum guy, but I'll fix some ankles and some both
That's all
bones.
right. Save it for Monday. Save it
Hey,
for
yeah, yeah,
Monday.
exactly, right. Oh man. And so we do get a good amount of residents that listen to this podcast, and so you try to do some reflection. And so, what are one of the things if you had to go back and give yourself some advice starting off residency, right? What's some advice you would give yourself? Brand new, you're in it, it's day one,
Yeah.
and and you got these 5 years ahead of you.
Yeah, I feel you. So, the advice that I give myself is maybe different for advice that I give others. And everybody starts off with a different tendencies and different kind of personality, right? In the beginning of their training. And what you want to do is have kind of like a finalized end product that is consistently excellent, no matter what your starting point is. And so for me specifically, I would say that being in touch with this concept of harmony, and it's kind of like a soft skill, but understanding how to value and pursue harmonious, just kind of synchrony with just what's happening around you, whether that's with relationships, with your patients, just in general, like being part of like an infrastructure and a system, like having a harmony early and pursuing that with deliberate value, as opposed to like focusing purely on the measurables, right? Like purely on the objectives and like working really, really hard and trying to produce as much as possible. So, I think coupling production with harmony, that's like kind of like the secret sauce that drives a lot of leaders to their inspirational like roles in an institution and in teams. And if you can kind of try to master that earlier, or just at least be aware of those two not necessarily competing, but just those two dynamics, the sky's the limit. So yeah, always got to work hard, but make sure you stay harmonious with the environment around you.
Man, that's great. I feel like I could see that on a billboard somewhere. That was that was a great answer right there. I
Yeah.
like that.
That's my feedback to myself,
Right.
and through
It's good.
so other feedback may have to be for some other folks. You don't want to be a doormat, right? You don't want to be so
Yeah.
harmonious that you're not doing the right thing, for your patients or advocating for yourself, et cetera, your team. So you just have to understand your tendencies, and not all the feedback is pertinent to different folks, so take it for what it's worth.
Yeah, totally agree. And so now we can transition a little bit and talk about some open fractures and we'll break it all the way down for the person that has no idea what an open fracture is, and then we'll
Yeah.
get nice and complex. So just breaking it down, what is an open fracture at the end of the day?
Yeah, sure. So an open fracture to me is a fracture where the bone meets the world, right? Like, so the bone has penetrated the skin. And I say that in a particular way because, that is the clinically relevant classic definition of an open fracture. You have open fractures typically from blunt injury mechanisms, but you can also have this so-called, if you could kind of visualize me doing some quotations, open fracture from ballistic injuries, and that's when some projectile or some foreign body opened the skin and met the bone. That's different, right? So open fractures are typically characterized as when the bone opens the skin and meets the world, or is exposed through some type of violent soft tissue injury, by definition that is contaminated with the environment.
Yeah, I like that. That's a great distinction when the bone meets the skin, just like you mentioned, with gunshot wounds, because some people may treat those necessarily differently, or it's kind of a different mechanism, like you just
Right.
described. And one of the age old, morning conference questions
Oh,
are
yeah.
there any classification systems for these open
Yeah.
fractures? Any ones that people should know about, and I guess what are they?
Let's go through it. So,
Yeah,
give me a second here, so bear with me. So, it's the Gustilo-Anderson classification, and just for semantics, just to put the nail on the head here, because we're on the Nailed It podcast,
I
it's
like it.
type, not grade, not grade. If you say grade in fracture conference, you're gonna see an eyebrow being raised. It's not a grade, it's a type. So type 1 is the most benign of open fractures. These are the fractures that, yes, they are open. The bone met the world, but they tend to have a very small soft tissue injury. They tend to be so-called poke hole. They tend to have not very much soft, periosteal stripping, meaning that the bone has nice viability to it, and there isn't any bone loss. As well as those fractures are, typically managed with the ability to close the skin. So there isn't any issues with soft tissue loss. So that's our type 1. So type 2 is kind of a tweener. So let me get to type 3 and then we can define type 2. So type 1 is level set. Type 3 is when you have a higher energy mechanism, comminution, periosteal stripping, soft tissue injury with potentially a large skin laceration / abrasion or tension failure. Now, the reason why I say potentially skin issue that's large is because, formerly on, some of these websites, right, there's a measurement, right? And they say, oh, above 10 centimeters or whatever, that's a type 3. But the nuance is this, like, for example, if you have an open femur fracture from a blunt injury mechanism, that's by definition a type 3, because the amount of energy that required to have that femur bone go out through all the quad and hit the world was enough to cause classification for a type 3 injury, even if it was just poke hole. So don't let the skin fool you. It's really about understanding the energy that went through the fracture and whether or not there's comminution, bone loss, periosteal stripping, as well as soft tissue injury. And then you kind of backtrack to get to the type 2s. The type 2s are like kind of like not like type 1s, but not like type 3s, right? So they, don't necessarily have any bone loss, maybe have some mild periosteal stripping, but the majority of the periosteum is intact. These patients don't have any issues with skin loss either, so they can be managed with with immediate closure after proper debridement, and they don't tend to have very contaminated wounds. Pulling back to type 3 can have gross contamination or not. A lot of that's dependent upon whether the mechanism of injury and whether or not that patient had a tension failure of the skin versus had some type of sheared soft tissue that from the energy vector, and that ended up being basically scraped on the ground. So when it's been scraped on the ground, oftentimes, obviously if the patient didn't have any type of protective clothing or what have you, that allows for gross contamination. By that I mean visual dirt, grass, clothing, things like that. So that's the type 3 plus or minus gross contamination. And then the type 3 has 3 subtypes. Okay, so it has an A. Type 3A is a open fracture that is violent, has all the factors of a type 3 fracture, but also does not require any free soft tissue reconstruction like a free flap or have any vascular injury. It can be managed ultimately with primary closure, okay, of the skin. Type 3B is when you have a soft tissue injury such that you require free flap, okay? And it's not necessarily requiring a skin graft. That could still be a type 1A, or type 3A, excuse me. The type 3B requires some type of flap coverage because of soft tissue loss. So, and then type 3Cs, those are the ones with vascular injury that are, the so-called mangled extremity. One of the pet peeves I have is when folks say, oh, we have a partial amputation in the ED, or maybe actually you just have a type 3C open fracture that you need to spend a little more time diagnosing the x-rays and understanding what you're working with. So being specific, using the x-rays to inform the diagnosis for the amount of energy that was imparted on that fracture, looking at the soft tissue and the skin and not being fooled too much with the measurements, but understanding the bigger picture. That's kind of how we use our types, our gustilo-anderson classification formally as fracture surgeons.
Yeah, I love it because you answered questions I was going to ask, and as soon as I was about to say, you answered the question. So it was perfect. And so just to reiterate, somebody has a femur fracture, even if it's a poke hole, it is not a type 1 that is a type 3 just from the amount of shear energy and soft tissue stripping and periosteal stripping that went into that mechanism. Because I know that's something that I've seen a lot of people get confused about.
Right, right. And that's talk about blunt injury mechanisms. And then you
Right.
have these ballistic injuries, and that could be a whole different ballgame. But in summary, you have low velocity, MV squared, right? So kinetic energy, you have low velocity um, ballistic injuries, and then you have high velocity ballistic injuries. And if you have like an assault weapon that has a high velocity caliber that comes out, that can lead to some really devastating type 3 injuries because you have the associated kind of zone of injury from the soft tissue devastation from the impact. So, it's harder to kind of define that within the Gustilo-Anderson. I kind of
Right.
think about that with respect to mostly the blunt injury mechanisms.
Yeah, and you mentioned earlier the 3 Bs again that needed a soft tissue flap, not just a skin graft like Integra or something. And so for the 3 Cs, I've seen it some places. Is it a vascular injury that requires repair, or is it just
Yeah.
a vascular injury?
No, it requires repair. There's going to be little vessels. They may not have names. That's going to be, an issue, or, it's something that, basically you have a lack of perfusion to the distal extremity, right? So even if you have if you have runoff that perfuses the distal extremity and it doesn't require vascular repair to have perfusion of the foot, basically, then, you don't really have a type 3C. So I think it's by definition requires a vascular repair.
Yeah. And so say you have, a one of your interns or you have a second year resident that comes to you and tells you like, hey, we got this guy that has an open fracture of the tibia, and that's all they say. And the typical next question out of my mouth, well, what would that be out of your mouth, right? Like, well,
Yeah.
I don't know if you see what I'm trying to ask here,
Yeah, I know. The
but
reflexive. You got to have this orthopedic reflexive, like, kind of thought process, right? So the first thing, which is important, is timing of antibiotics. So you said, did the patient get antibiotics,
yeah,
right? So, that is something that we need to know that is important to communicate to our emergency medicine colleagues when we get consulted right away in that first moment. Did you give antibiotics? Did you give tetanus? Because timing of antibiotics matters as well as the quality of surgical debridement. And we could talk about that latter surgical treatment
yeah,
but in terms of antibiotics, just to kind of, maybe kind of dive a little deeper,
yeah.
you
Go ahead.
for the type 1s and 2s, you want to make sure you cover for gram-positive bugs. It's the same antibiotics that we give for perioperative antibiotics. So you give some type of Ancef, cefalozone, what have you, something like that, right? Something IV within 60 minutes. You need to cover for gram-positives essentially. For the type 3s, and these are the ones that plus or minus gross contamination. You need to start covering for some gram negatives in addition to gram positives. One of the newer kind of strategies for this is with ceftriaxone, some third generation cephalosporin. There used to be something related to like using it like, kind of historically it was like, some type of like, Ancef plus aminoglycoside, but that can lead to some renal toxicity. So I think these days it's more popular, at least according to the majority of institutions, depending on where you practice in your local kind of microbe environment. The most popular to do is just like a ceftriaxone or something like that, like a third generation cephalosporin for type 3s. And
Yep.
then if you have like basically like fecal contamination, farm injury, like gross dirt, all that stuff. You just have to make sure you have coverage for anaerobics. And there's some nuances with fresh water, but those are the biggest principles there.
Okay. Okay. Good. So again, for the patients that have these, these gross contamination, especially with farm animals, cover for the anaerobics, and then you mentioned the first generation kind of cephalosporins for the type 1s, and then abroad, like something like ceftriaxone that you mentioned for maybe some of these type 3s,
Type threes,
and
yes, sir.
and all the stuff like you were just mentioning with the salt water and the fresh water, for those of us or for those that are doing residency in these areas where they get a lot of these kind of aquatic injuries, what should like what organisms, like what are some things that should be on their mind, and what other
Yeah.
things should they
You
get?
know, that one I would look up, be honest with you, because I think at that point things could be a little bit exotic.
Yeah.
Maybe consult with your infectious disease doctors. They're not going to necessarily ask that on some of these standardized exams, but in practice, in reality, for some of these more exotic injuries, you want to make sure that you're thinking outside the box a little bit and consulting with your ID doc.
So you mentioned earlier about number one, of course, getting antibiotics, timely antibiotics, and you
Yeah.
mentioned a debridement
Yeah.
irrigation. So, that's kind of our treatment for, these open fractures. But what goes into, like, say, they got their antibiotics when they came in the door. It's a type 3A open fracture of the tibia with some contamination, and you're taking it back to the OR. What constitutes a thorough debridement and irrigation? And is there any way that you think of how you perform this surgery in your head to make sure you don't miss anything?
Yeah, so let's definitely dive into that. Let me finish the ED stuff real quick. So
Yeah.
antibiotics is important, and then you want to. This is variable between institution, but you do want to have a sterile dressing on it and have a reduction in skeletal stabilization with a splint. The stability imparted by, the skeleton helps the soft tissues recover. So if you can manage some of that fracture instability with a splint, that's going to serve your soft tissues well. Also, in terms of whether or not you do some irrigation in the ED or not, right? For me, if it happens, that's great. If you put a sterile dressing on, that's great. The reality of it is that if there's gross contamination, we're going to go to the OR on a semi-urgent basis, right? So gross contamination, and that means, I mean, it's kind of like you know it when you see it, right? But gross contamination gets me up in the middle of the night, and I will do that kind of urgently. That is pretty much within 6 hours or so. But in the absence of gross contamination, that's typically a prioritized case within 24 hours to do a formal debridement and irrigation. I say it in that sequence because the debridement is what matters the most, right? It's not the irrigation and sprinkling a little water in there or saline, what have you. It's actually the surgical technical part, and oftentimes the debridements are left to the most junior surgeon in the room, and oftentimes
Yeah.
it's the most critical issue for the patient's overall outcome. So we
Right.
may want to consider that debris mounts aren't something to just be doing while you're irrigating as you're cutting out, any gross contamination. You want to focus on that step initially. And I say cut out because you want to sharply excise any grossly contaminated tissue, bone. You want to be systematic about it. So the way I do it is, I start with the bone. I expose the bone ends. So, one thing to have to keep in mind is another pearl is typically, if not almost always, right? It's the distal end of the proximal segment, the distal end of the proximal segment that meets the world. That's the one that made that skin penetration. That's the one you got to go really fine and scrutinize and see if there's any gross contamination on that tip of that spike. And that's the one that's often, if you're not thinking about it, missed. And that could predispose you to having fracture-related infection down the line. I think that so working systematically, getting your 15 blade out, obviously not causing any harm, right? Knowing your anatomy and knowing what's intact and not just going crazy with it, but using your 15 blade to cut out any um, damaged, that is like clearly devitalized tissue, and basically debriding your bone so that you have clean fracture edges. Now this is super nuanced. Like I don't know how deep you want to go, my man, but
Let's
we could
go.
talk
Let's go
about
deep.
it. All right,
Yeah,
all right,
let's go for it.
all right. Let's do it. So you do your debris mod, right? And so you start systematically, you start deep to superficial, you go from the bone to the muscle to the skin. You're not excising skin. Skin is precious, but you are just making sure there's no gross contamination. If the skin edges have gross contamination, then that has to be excised. But that's very, very rare. And you can typically just kind of scrape that away or just invigorate the skin. You don't want to just cut skin, like, skin is precious. And like I said, most of these open fractures have tension failures of the skin. They don't have skin loss, so they can be closed after a proper debridement initially. And immediate closure actually mitigates risk of infection and non-union if you perform the adequate debridement. Okay, and that's a big if. So, just doing a debridement and not spending the time and care to close the skin after you did a debridement is kind of a little bit nihilistic. You want to spend that time at that point, if you have a clean wound bed and clean fracture, to do a definitive closure. And if you have a clean wound bed and a clean fracture, you might as well do some definitive fixation, or at least provisional, as you have that gift of that wound right in front of you to get some skeletal stability internally. So oftentimes you'll see me, if I have an open tibia fracture, like these are the most common, open 3A tibia fracture, right? I'm working through that open wound, or I'm making a counter incision because I do not extend medial wounds on the medial face of the tibia because that's a very high risk. So I'll make an anterolateral counter incision and book open the bone through that incision because that has the tibia and musculature on top of it to be able to allow for some muscle coverage on top of the bone. In case the skin gets an issue, that's another conversation. Understand counter incisions can be important. But going back to this, what we're talking about with the tibia, if I had a open tibia that I had a proper debridement with and had the ability to close the skin primarily, which is most of them, I'm going to do something to stabilize that skeleton, probably definitively. So I'm going to put maybe a unicortical plate, um, using that open wound with a direct reduction because that biologic cost is already imparted by the injury. And then I'm going to place a nail, with that reduction already set after that wound has been closed. So the reaming stay inside and all that biology stays at that fracture site, and then place my definitive nail. So that's early, immediate fixation, and with the proper wound closure and primary closure. That actually, if you can do that with a big asterisk that you've had an adequate debridement, and there isn't going to be any subsequent declaration, of necrotic tissue, which is based upon the energy of the soft tissue that was received, then that mitigates risk of infection and non-union. So that's like a super long-winded, kind of complex answer to your question. In summary,
No, it's perfect.
yeah, no, but just to recap, like highlights of that, like, immediate primary closure is safe and effective if you performed an adequate debridement. You really shouldn't be leaving the OR until you see no dirt. So if you did a debridement, you did an IND, you irrigated with just like saline, no pressurized pulsatile saline. That's been disproved by the flow trial. So that just pushes bad stuff into the soft tissue. So just cysto tubing. And then you reassess the wound and there's more dirt, you got to start over. And y'all, my residents will tell you, we spent a few hours sometimes debriding until there's no dirt because
Yep.
it's not that complicated. It just takes a little bit of tenacity and kind of passion to get that done, right? It's kind of like a labor of love to do the debridement for the patient because it can be painful for the surgeon. But you need to kind of be very scrutinizing, look through all the little crevices, and not leave any dirt in the wound. The last point that I want to say is this. There was a study out of WashU looking at WashU, and I think institution in Texas, but they looked at two institutions where they had a retrospective study trying to understand if you had to prioritize debridement versus prioritize like non-union risk, right? So there's a dichotomy, right? Aggressive debridement, you're going to have increased non-union risk theoretically.
Yeah.
Insufficient debridement, you're going to have higher infection risk theoretically. Okay. So if you had to choose which one to err on the side of, right? I'm not saying leaving any gross contamination, but say there's a devitalized bone segment or something that has very stripped soft tissue that you feel like, may have a few strands on it, but man, it's tenuous. Actually, that paper would suggest that it is better to lean towards keeping that bone versus aggressively debriding that bone because the group that did better actually was the one that had the more judicious debridement as opposed to the more aggressive debridement. They didn't show an increase in infections from the judicious debridement group. So that's a really important paper, like for like the connoisseurs out there when they're trying to make intraoperative decision making on whether or not to keep this piece of bone that may be clean but has like some strands of soft tissue on it. I tend to keep those, and that's just been my preference.
No, that was a great well, that was a great explanation and a good summary. And a couple of things I wanted to
Okay.
highlight is that you mentioned is not extending that medial wound when you have like an open tibia fracture, right? And making a counter incision laterally and debriding through that wound. And then also, when you're doing your debridement, right, you mentioned exposing or delivering those two ends of the bones and doing a sharp debridement. Are you also using like a curette and debriding out and trying to get contamination out of the canal, or are you just
Good question.
irrigating that?
Yeah, I don't really see much contamination in the canal. Like it doesn't really go up there like that. It's really that the fracture edges is mostly the distal and the proximal segment. I don't take a curette. I don't really use curettes in general, personally. I think they can kind of remove more bone than is necessary or intended, and it's a little bit of a macro type instrument. So I actually use a narrow sucker tip that has suction on it, and you'll see me use that, and it'll suck through the bony crevices, like all the gross contamination. It's a really good debridement tool, and it keeps the bone that you want to stay, so you're not causing any nitrogen, but it also gets rid of the free fragments or the gross debris as well.
And you also mentioned earlier that we have these fractures and we want to close them primarily. So say we have something three, I guess technically 3B, but
Yeah.
say you have something
Yeah.
where that you can't close the wound.
Okay.
When do you like ideally when do you want that wound to be
Yeah.
covered with some type of a flap or whatever else it may be?
Yeah, let's get into it. So I'll definitely answer that question, but let's talk about skin closure. So,
Yeah.
basically, you do want to be very careful and sensitive to the soft tissues as you're going through this process of managing the skin. You don't want to be pinching the skin. I don't use anything but vertical mattress suture or Algauer Donatis. I do not use horizontal mattress. I don't do a running stitch. I don't do things to save time. I do things to save the skin. So, basically, you want to have a stitch that allows for the most amount of oxygen perfusion to the skin with still allowing you to set tension in a way that makes the skin close, but not over constrict it so the skin can't breathe. So, I encourage you all to look up the Algauer Donati suture technique because this is how you can have amazing results with very devastating soft tissue skin injuries that have no skin loss, and you can get them closed primarily predictably. You don't need to really be, I don't really know how to do skin grafts because either there is skin loss and it's not getting a skin graft for me because that typically needs a flap because there's some soft tissue muscle issue, or there isn't and I'm getting it closed primarily. So let's talk about the three B's. Time to flap coverage, fix and flap is important. So the literature now I think would suggest that earlier is better, but 5 days is kind of like that time where you are concerned about having increased infection and non-union rate if you have definitively fixed a fracture and have had it uncovered for an extended period of time. And sometimes what you want to do is you could do it at the same time, but it's kind of burdensome to the flap surgeons, to go after you at the end of the day and do a free flap. So what I've done and had pretty good results with our team, and it's a team effort for these kind of limb salvage cases, is I will do a definitive fixation and then put a wound vac or an antibiotic bead pouch, never wet to dry, something sterile. So an antibiotic bead pouch or a wound vac, and then having that patient be scheduled for their free flap the next day with our plastic surgeon. That's pretty good. Like that's reasonable in terms of work flow and still abides by kind of that metric of 5 days.
Yeah. No, that's great. We did Very similar things in residency, as far as coordinating with the different teams. It's like how you described a debridement or debridement. Let me ask you this: debridement
Yeah.
versus debridement. Oh,
Where did you
wait,
train?
wait,
I can tell you're a
wait.
connoisseur. Where did you go to residency? Who your
I did it
trauma
at Tulane
Oh, so
University.
you're a
So I
PG
had,
guy. So
yeah,
now you
yeah,
know
yeah,
what's up. So I was like, oh, okay, I understand. Shout out to
yeah,
Gladden.
yeah,
So
yeah, yeah.
yeah, so I call it debris month, because I'm cut a little bit from the same Gladden cloth. But I will say that debris month doesn't matter. I just need to do a good job at
That's
it.
great. And so I think we did a great job covering open fractures. Even as an attending, you still learn something whenever you talk to somebody. And I always learn something from all our guests, and I hope the people listening learn something. But anything else that you want the people listening to know about open fractures, it could be anything from management, how to treat them, anything that you want the people to know about it.
Yeah, no, I think that management of open fractures can be challenging, especially the ones that are the more violent injuries, the soft tissue loss. I think that challenge, is an opportunity, right? It's an opportunity to show how much you care about that patient, how focused you are on the details that matter, because you have a big opportunity to make a huge difference in that patient's outcome based upon your surgical tactics and execution and essentially the values that you kind of put in to that patient on the table. So, I think that open fraction management is something that we all should take, very, very seriously, just in general for orthopedic surgeons, because there's a great opportunity to do great good to your patient and optimize their outcomes. But there also is a pretty not insignificant risk of being too nihilistic about it and subjecting patients to poor outcomes by blaming the injury when they could be potentially avoided with better surgical tactics.
Yeah, yeah, I totally agree. And again, Dr. Bond, it's been great having you on the podcast. Thank you so much for coming on again and blessing us with this knowledge for how to manage these different open fractures and actually dropping a couple of papers. One that I definitely want to go check out that I hadn't heard of before, that last one
Yeah,
that you talked about. So
yeah,
yeah, definitely gonna
that's a
check that
Bill
out.
Ritchie paper out of WashU. Bill Ritchie, I think Gardner may be on that one.
Yeah,
Yeah.
I'm gonna go check it out. But again, thanks so much for being a guest on the podcast. Those that are listening, we hope that you enjoyed the episode. Go and leave us a review. Let us know how much you enjoyed it. And then next time you have an open fracture, hopefully you think about all the different steps that we talked about in this podcast and you can manage these appropriately. So again, thanks for coming on the podcast.
Anytime. Good job. Thank you.